Very good morning to all of you, and wishing you all a very happy and prosperous new year 2024. So I begin with my talk on natural history and outcome of pediatric primary sclerosing cholangitis. So I will give my talk under these headings. So I will cover some of the adult PSC data also, and also will try to compare the adult PSC with pediatric primary sclerosing cholangitis. So how to define primary sclerosing cholangitis as per the consensus statement published in 2021 in gastroenterology. So primary sclerosing cholangitis is inflammation and progressive fibrosis of intra and extrahepatic bile ducts in the absence of known etiology. That is, the secondary sclerosing cholangitis should be excluded, which happens in the pediatric age group in the setting of either HIV, primary immunodeficiency like hyper-IgM syndrome, chronic granulomatous disease, or rarely in tuberculosis, and also with Langerhans cell histiocytosis. So this is adult consensus. So how did they define the large duct and small duct PSC? So large duct PSC is when there is absence of the secondary sclerosing cholangitis and the ductal changes are demonstrated on a high quality MRCP on 1.5 Tesla or a compatible ERCP with features, compatible features along with one out of these parameters like elevated alkaline phosphatase or GGT in elevated GGT in children, concurrent clinical or histological features of IBD, and then histological features compatible with PSC. So what are the compatible MRCP and ERCP changes? So these are the bile duct changes with multifocal strictures and or segmental dilatations in the intra and or extrahepatic biliary tree. And how did they define small duct PSC? Small duct PSC is when the MRCP and ERCP are normal and histological features are typical of PSC, or if they are not very typical, compatible, so then in the presence of IBD and increased alkaline phosphatase. So what are the histological criteria? So typical criteria is the onion skin fibrosis, fibro-obliterative ductal lesions, which are seen in less than 20% of the patients. And whereas compatible lesions are biliary changes with duct loss, ductal reaction, biliary pattern of interface activity, and chronic cholestasis. And atypical changes when there is more of inflammation or steatosis, suggesting some alternative diagnosis. And also the disease is said to be progress histologically when there is increase in fibrosis or there is duct loss or evidence of chronic cholestasis or deposition of copper associated protein. So liver biopsy, they have mentioned that in a patient with suspected PSC, when the MRCP is normal and you are suspecting small duct PSC, then it should be done. And also in patients with suspected overlap, that is autoimmune features, so then also liver biopsy is recommended. So these are the EASL guidelines for primary sclerosing cholangitis. That is when there is elevation of alkaline phosphatase and GGT with or without elevation of bilirubin, a detailed history, physical examination, ultrasound to look for dilatation, stones, and also then proceed to antibodies, anti-nuclear, anti-mitochondrial antibodies are not done for children. So, but when they are positive, the diagnosis of primary biliary cholangitis is made. Then ERCP, MRCP to look for the cholangitis features, then liver biopsy to look for whether it is just biliary disease or a parenchymal, that is an overlap, or just primary sclerosing cholangitis. And if nothing is suggested, then genetic analysis is also suggested, like some diseases like MDR3, ABCB4 deficiency can also mimic primary sclerosing cholangitis. So this is a broad differential diagnosis of PSC. Inflammatory, that is IgG4, stone disease, sarcoidosis, graft versus host disease, amyloidosis, or vascular like ischemic cholangiopathy in the setting of radiation injury or portal vein occlusion. Then infectious causes like AIDS cholangiopathy, ascariasis, liver fluke, neoplastic like Langerhans cell histiocytosis in children, or cholangiocarcinoma in adults. Then genetic causes like MDR3, developmental causes like ductal plate malformation, then immunodeficiencies like hyper-IgM syndrome, and rarely drugs can also cause a similar picture. So laboratory tests may actually point out that this may be an overlap when in the setting of elevated alkaline phosphatase or GGT, there is also elevation of transaminases more than 5 times or IgG is more than 2 times upper limit of normal, that will suggest overlap. And in terms of response to immunosuppression, PSC will not respond to immunosuppression. AIH will respond. Overlap will also respond but poorly than AIH, but PSC will not respond. and autoantibodies may be present in PSC patients. IgG4 may also be elevated in 25% of PSC patients, but if the levels are more than 4 times of upper limit of normal, or if the IgG4 is to IgG ratio is more than 0.24, so that helps in differentiating PSC from IgG4 disease. So histological staging in terms of Ludwig or Nakanuma staging. So Ludwig is the commonly used histological system where it is staged from 1 to 4. That is cholangitis, periportal hepatitis or fibrosis, septal or biliary cirrhosis. So these are in this picture, these are the typical obliterative lesions which are suggestive of an end-stage primary sclerosing cholangitis. So cirrhosis is further defined on the basis of non-invasive tests like the elastography when it is more than 14.4, enhanced liver fibrosis score of more than 9.8, and fibrotest more than 7.3. So what about autoimmune hepatitis and primary sclerosing cholangitis? Are they spectrum of the similar disease or are they different? Like we know that in autoimmune hepatitis it is more of portal inflammation, plasma cells, whereas in PSC there is lack of inflammation but mainly ductal changes, periductal fibrosis. But in between the overlap will have inflammatory as well as the biliary changes. So this is a very good study from King's, and this is a very well quoted study in children where they compare 28 autoimmune hepatitis cases with 27 autoimmune sclerosing cholangitis children, which was defined on the basis of the MRCP changes, and they differentiated on the basis of the clinical features like IBD was more prominent, was more common, often seen with the ESC cohort. Biliary changes on histology were more commonly seen with the autoimmune sclerosing cholangitis, whereas in the autoimmune cohort there was more of parenchymal features like coagulopathy, hypoalbuminemia, periportal hepatitis, and also there was more of HLA-DR3. And the ASC patients also, there was in 1/3 of the patient there was progressive cholangiopathy, and 4 of the ASC patients required liver transplant. So this is a recent review published in Journal of Hepatology. So where it is mentioned that this may be this AIH and PSC, this may be a coincidental occurrence shown on the left hand side, or this may be just an overlapping features AIH and PSC, which is the most often seen scenario. Or the third scenario is when the AIH, PSC and the overlap, so they all three are presenting as a distinct disease entity. Other thing is the overlap may happen in the setting of the AIH when the biliary changes may progress because of the inflammation of the ducts and duct destruction, and in the setting of the PSC there is more of inflammation, so then it is predominantly PSC and subsequently overlap. So this has been proposed that from childhood there is more of inflammation, so it is immune mediated hepatitis. There is increase in transaminases, increase IgG levels, and there is initially biochemical response to immunosuppression, which is subsequently followed by destruction of the bile ducts, and there is mixed hepatitis biliary picture on histology, and on MRCP there may be changes suggesting sclerosing cholangitis, and later on in young adulthood to later on in life, so there are multifocal biliary strictures, so leading to non-response to immunosuppression, biliary disease, and there is more increase in elevation of alkaline phosphatase and GGT in contrast to the transaminases. And also simultaneously there is progression of the colonic changes from normal colon to colitis. So the MRCP changes may not actually be sclerosing cholangitis. Like there are so many studies in adults where a cirrhotic liver may also have the biliary features, which may actually wrongly point towards sclerosing cholangitis, but the changes are not due to sclerosing cholangitis. Like this is a study from SGPGI in children where 38 autoimmune hepatitis cases were compared with 19 Wilson disease children, and it was found and definite changes of sclerosing cholangitis were labeled when there were multiple biliary strictures with proximal dilatation. And so overall abnormal MRCP changes in the form of irregularities or some atrophy, ductal irregularity, narrowing, or some focal narrowing, or some beaded appearance. So they were seen in around 14 AIH patients and 8 out of the Wilson disease patients out of 19. But the definite changes of autoimmune sclerosing cholangitis were present only in 4 of the patients of autoimmune hepatitis, but not present in the Wilson disease cohort. So Coming to briefly about pathogenesis. So primary sclerosing cholangitis is a multifactorial disease which may be, so there is some role of genetics like HLA-DR3, HLA-DR6, 13 and B8, and also there are certain risk loci which has been defined on whole exome sequencing. Then there is role of gut microbiota, there is decrease alpha diversity, and also increase in certain bacterial species like Streptococcus, Veillonella, and also decrease in certain species like Bloschia, parabacteroides. And also there is leaky gut hypothesis, and also role of bile acids and immune response, both innate as well as adaptive. So coming to epidemiology, so this is in adults. So where it is mentioned that the overall prevalence as well as incidence of primary sclerosing cholangitis is on rise, and with the development of primary sclerosing cholangitis, there are more of liver-related deaths, around 40 to 80%, and 8% may be related to colorectal carcinoma. And overall, in 10 years period, 20% may develop complications related to portal hypertension or decomposition. So this is the compilation of various studies on epidemiology and natural history. In childhood, in contrast to autoimmune hepatitis, so this is a disease more often seen in males, predominantly more than 10 years of age. So this is the largest data on primary sclerosing cholangitis in children, 781 patients. So 33% had autoimmune hepatitis, 76% had IBD, and 13% had small duct primary sclerosing cholangitis. And it was found that means over a period of 10-year follow-up, so it was seen that portal hypertensive complications were seen in 38% and biliary complications were seen in 25%. And after the development of these complications, the median survival with native liver was just 2.8 and 3.5 years. Overall cholangiocarcinoma in the pediatric age group was 1%. So these are the curves showing progressively increase in the portal hypertensive complications. So at 10 years, around 38% developed portal hypertension, and biliary complications at 10 years around 25%, and progressively there was decrease in the survival with the native liver. So what about adult versus pediatric primary sclerosing cholangitis? So this one study compared adult versus pediatric, and they mentioned that adult diagnosed primary sclerosing cholangitis, they have more adverse outcomes in terms of liver transplant, death, or cholangiocarcinoma. They have more portal hypertension, more biliary complications, and decomposition. So what about impact of primary sclerosing cholangitis on autoimmune hepatitis? So this is the data from King's in adults. So where 238 autoimmune hepatitis patients were compared with PBC-AIH overlap and 16 PSC-AIH overlap, and it was found that there was poor survival in the PSC-AIH overlap AIH cohort in comparison to simple autoimmune hepatitis as well as with the PBC-AIH overlap. So these patients, they concluded that PSC-AIH overlap indicates a severe disease and worse prognosis than simple AIH or PBC-AIH overlap, and their recognition and close follow-up is mandatory. So this is a large data from the international autoimmune hepatitis cohort, where the predictors of poor outcome. So one of the predictor of poor outcome, apart from cirrhosis and lack of complete biochemical response within 6 months, so one of the predictor of poor outcome was the overlap syndrome with PSC, with primary sclerosing cholangitis. What about Indian data? So this is the only study on autoimmune hepatitis, large in a study from PGH Chandigarh, where 275 patients were analyzed, and overall PSC incidence, the overall AIH PSC is around 6.5%. So this is actually a mixed bag of autoimmune liver conditions. So there is no other data. Unfortunately, we do not have any autoimmune data, the data on autoimmune from ILBS. So the complete biochemical response which they mentioned was seen in 60%, and predictors were found to be high ELT, high albumin, and low fibrosis. But these predictors do not mean anything, because this was a mixed bag of immune conditions. So what about predictors of survival in pediatric autoimmune hepatitis? So again, in this cohort of 819 patients, so one of the risk factor was overlap, that is autoimmune sclerosing cholangitis, which was associated with risk of death or liver transplant. So the best predictors as per this study of survival with native liver in pediatric autoimmune hepatitis was AIH type 2, normal C3 levels at diagnosis, and remission, and also normal cholangiogram. So if the cholangiogram is abnormal, suggesting sclerosing cholangitis, so that actually indicates a poor prognosis. So coming to what is the impact of IBD on primary sclerosing cholangitis. So this is a study, large data of around more than 7,000 patients. 90% were large duct PSC and 70% had IBD. So out of these 7,000 patients, around 2,600 had liver transplant or death, and around 10% had hepatobiliary malignancy, predominantly cholangiocarcinoma. So on multivariate analysis, it was found that small duct PSC was protective in both the genders, whereas ulcerative colitis was associated with the worse outcome. So before this study, there were other studies also in adults where there was conflicting data, whether IBD is protective or whether IBD is associated with an unfavorable outcome. But as per this data, this is the largest data. So ulcerative colitis is associated with the worst outcome in comparison to presence either Crohn's disease or with no IBD. So these are the curves where we can see that the small duct PSC is associated with a better outcome in comparison to a classical PSC, and also Crohn's ulcerative colitis is associated with the worse outcome in comparison to Crohn's or no IBD, and the outcome in terms of survival as well as development of cholangiocarcinoma. So what about PSC IBD in children? So there are studies which mention that PSC IBD usually have a milder course. So this is the data from Boston, 120 patients, where the 27% had ASC and 24% had small duct PSC, and IBD was present in 81% of the patient, and overall 10-year liver transplant free survival was 89%. So they mentioned that ASC and PSC, that is autoimmune sclerosing, that is overlap or isolated PSC, had similar biochemical abnormalities and degree of fibrosis, and PSC that developed after IBD diagnosis had a milder course. So this was the conclusion. I will come to this later also, what was the postulate as per the other studies. So this is another study from King's, 82 children who were followed up the ulcerative colitis, 82 with IBD and PSC. So whole of this cohort was IBD and PSC. Ulcerative colitis was in 55%, and they mentioned that because this was a multi-center study, few of the patients were from gastroenterology center and other children were from the hepatology center, and they mentioned that when the liver disease is diagnosed sooner after the diagnosis of IBD, so that was associated with less liver-related complications during follow-up. So this is again the largest data which I showed earlier. So as per this data, so they mentioned that the small duct PSC was protective, and also the IBD was protective in terms of the liver-related complications, overall survival, as well as the liver transplant-free survival. So the postulate for why this IBD is actually showing a protective effect was that this was possibly a lead time bias, that these patients were diagnosed early, they are often closely monitored, and they have lesser prognostic scores, Mayo risk scores, and they possibly were started early on UDCA therapy. So that's why they have actually less liver disease in comparison to those who have just isolated PSC. And also it was postulated that PSC ulcerative colitis have different biology and behavior, and as per a genomic study, there was a gene which was mentioned, MST1, macrophage stimulating 1 gene, which was implicated in pathogenesis of both IBD and PSC. So this PSC along with IBD may actually be a different disease. So now next thing is, what is the impact of primary sclerosing cholangitis on IBD? So this is again a large data published in from the Adults Gastroenterology 2020. So where more than 2,500 patients of more than 2.8 lakh patients of IBD were studied, and out of these 2,500 developed PSC. So development of PSC was found to be associated with increased risk of colorectal cancer as well as other malignancies like HCC, CA pancreas, CAGB, and also the liver transplant and PSC related events were more seen in the younger patients when the disease was diagnosed at a young age, less than 40 years in comparison to more than 60 years. So this is the poster of this study, where again we can see here that with younger age there was more mortality, more colorectal cancer. Female gender was protective for the liver related events. So coming to prognosis, So some of the factors we have already discussed, that like in adults, this is as per the Mayo risk score, that younger age, female gender, small duct disease, Crohn's disease, and normal or mildly elevated ALP are good prognostic factors, whereas extensive intra and extrahepatic biliary involvement is a poor prognostic factor. In children, good prognostic factors are small duct PSC, IBD, whereas poor prognostic factors are high bilirubin, GGT, alkaline phosphatase, APRI, and large duct abnormalities on MRCP. So adults, these are the various scores: Mayo, Amsterdam, Oxford, enhanced liver fibrosis, UKPSC, and a Presto model. So these are the various combinations which have been used: age, bilirubin, AST, platelets, varicose bleed, and sodium, albumin. So a combination has been used by these scoring systems. So what about children? So this is again the data from the largest PSC cohort, where the SAP, GGT, bilirubin, and APRI have been shown to be significantly associated to affect the event-free survival. And so a scope index has been devised, so which was applied in 1000, which was derived in from a cohort of 1000, around 1000 PSC cases, pediatric cases from 40 centers, and this was subsequently validated in 240 children. And the various variables which come out in this scope indexes were bilirubin, albumin, platelet count, GGT, and abnormal cholangiography. So this was, so as per the values were added to give a scope index from 0 to 11, and the risk categories were given as low, medium, or high, and on the basis of these risk categories, the probability of development of transplant or death in the next 5 years, or development of hepatobiliary complications in the next 5 years, so as per this chart, have been made. So risk stratification, so this is as per the adult data: small duct PSC or a classical PSC with normal bilirubin, albumin, platelets, or with LSM less than 6.5, and with limited biliary changes on MRI. So these are low risk PSC, whereas significant risk PSC are when the patient is symptomatic, high alkaline phosphatase, high LSM of more than 9.9, or LF, or the ELF score of more than 10.6, or extensive biliary changes indicate significant risk for development of hepatobiliary complications. So how should we monitor? So the routine surveillance is required with MRCP, colonoscopy, fibroscan every 6 monthly to yearly, and DEXA scan. Additional workup is required to look for hepatobiliary malignancy, and if there is associated AIH, then IgG antibodies, and also look for portal hypertension. So what drugs? I will just touch this briefly. Steroids, UDC. Steroids are only indicated when there is overlap, and UDCA in a dose of 15 to 20, and it is recommended then when you go up to a dose of around 30, then there is increased risk of neoplasia. And long-term antibiotics only indicated when the patient is already had an episode of cholangitis or recurrent cholangitis. For pruritus, various medications have been proposed. So some of these are in pipeline, like bezafibrate, ASBT inhibitors, and PPR alpha and delta agonists. So when the strictures are there, particularly when the biliary stricture on MRI or MRCP is more than 75, when there is reduction of more than 75% of the duct diameter in the common bile duct or in the hepatic ducts, so then the ERCP is definitely indicated, or in the presence of cholangitis or obstruction. So next is oral vancomycin. So this is a retrospective study, propensity score matched study in pediatric population. 3 groups: oral vancomycin, UDCA, and without any vancomycin and UDCA. But the outcomes were comparable in terms of GGT, fibrosis stage, or in terms of need for liver transplantation. So this is another study from Italy, where 12 children received oral vancomycin, where they did not show any response to standard immunosuppression, which was given for either autoimmune hepatitis or for overlap, and they found that the response rate increased from 81% to 92%. So out of these 12, 8 patients responded to oral vancomycin. So this is, I will just cut this short. So this is data on vedolizumab, which is alpha-4 beta-7 integrin antibody, which is used for IBD. So there was some response shown in PSC, but there was no definite improvement in the liver biochemistry. So what about ILBS data? So we had 32 patients with large duct primary sclerosing cholangitis. In this data, we did not analyze small duct PSC. So 21 were males, and we excluded 14 secondary sclerosing cholangitis due to LCH, HIV, hyper IgM syndrome, and tubercular. So overall, we had 17 PSC overlap and 15 isolated PSC. So these PSC overlap and isolated PSC, they were almost comparable in terms of all the features in terms of demography or the clinical presentation, except for pruritus, which was more often seen with isolated PSC. And also in terms of the various biochemical parameters, they were all comparable, and also the FibroScan values were comparable. So in terms of the autoantibody profile, the ANA was more positive with the PSC overlap, which is obvious, and histologically there was more of portal inflammation in PSC overlap and interface hepatitis in PSC overlap in comparison to isolated overlap group. So what about outcome? The 5 of the patients had in the PSC overlap group had poor outcome in comparison to 6 out of 15 patients in the isolated PSC group, but this difference was not significant. So overall, 6 patients lost to follow-up, and 26 were followed up for a median duration of around 28 months. And there was poor outcome in around 42%, so which is significantly very high in comparison if we compare our AIH cohort, which was published around 4 or 5 years back. So where the outcome was very good. So these PSC patients have actually very poor outcome. 42% had poor outcome in terms of death or need for liver transplantation. And predictors which we found were biliary disease, portal hypertension, and ascites, which were obvious, but ulcerative colitis again showed a protective influence. So the odds ratio of 0.41. And there was no association with gender, presence of autoimmune hepatitis, or advanced fibrosis. So 8 patients were listed, and 6 underwent liver transplantation. And post-liver transplant, there was 1 death due to immediate sepsis post-liver transplant. 1 had recurrence of PSC, and he died of biliary complications awaiting retransplantation. And 1 had chronic rejection, which was treated with ATG, and 1 patient developed metabolic syndrome 3 years post-liver transplant. So this is our ILBS protocol. So all children with autoimmune hepatitis who have high GGT or biliary dilatation or poor response, so in those patients, in those selected category, we do MRCP to look for the biliary changes if they have, to look for autoimmune overlap syndrome, and we continue with the immunosuppression. Next other cohort is isolated PSC. So both of these cohorts, we look for screen for IBD, we give them UDCA, and we regularly monitor for biliary complications in terms of cholangitis, stricture or cholangiocarcinoma, and portal hypertension. And along with that, the other therapies are like optional, not for all the patients we give, like rifampicin, cholestyramine, oral vancomycin we have tried for 2 or 3 children, and prophylactic cyclic antibiotics or rifaximin which we give only in the event of definite cholangitis. Thank you. Thank you, and Happy New Year again.